Good evening, everyone. Thank you for joining today on a discussion on breast cancer challenges in care for better survivorship. Today is 31st and it's the last date of Breast Cancer Awareness Month. However, we should continue to keep the momentum of breast cancer awareness going on as an ongoing activity because it's a critical topic. But as awareness of breast cancer improves and more people get treated, we should also be looking at factors that influence not just cancer outcomes, but also quality of life of patients who live with breast cancer or, after their breast cancer treatment. Today, we will talk about the various pillars of survivorship, what they are and how they need to be managed. We are very privileged to have with us a pan-India panel of oncologists. And we also have Neeta Ben Vyas, who is not only a very experienced person in the field of physiotherapy. She was a principal of a college in Ahmedabad, but she's also a breast cancer survivor herself for over 5 years now. And that really has given her very unique perspective. We also would like to thank Biocon Biologics for supporting this initiative with us. I will introduce the rest of the panelists in just a moment. A quick reminder, Patients Engage is an online platform for patients dealing with chronic diseases and their caregivers to share personal experiences, information, and learn from each other. We strongly believe that, the better informed patients and their families are, the better choices they make and can do various things to improve their quality of life. So, do make sure that you check out the website as well as the content we have. We put patients and survivors at the center of a lot of our content. As you can see, we cover various aspects of living with cancer, and we've spoken to many patients and survivors over the years. And you can find all of this content on our YouTube channel as well. Quick reminder to our viewers, the views expressed in this discussion are of the panelists, are only meant for spreading general awareness. They do not necessarily reflect those of the platform or of the sponsor. The information discussed here does not replace a medical consultation, so please do go and discuss with your doctor for specific medical issues. We will be taking questions. The session is live on both Patients Engage channel as well as Biocon Biologics, so you can post your questions on the Zoom link here or on our Facebook page or the YouTube pages of either Biocon or ours, or you can reach out to us later on through our website, www.patientsengage.com. So let me introduce our panelists, and this was the last session we did earlier on the challenges in early diagnosis. You can find this again in our recordings. So today's panel includes, we have with us Dr. Meena Sudan, who will be joining us in a few minutes. She's a radiation oncologist from Amritsar. We have Dr. Mithun Shah, medical oncologist from Zydus Hospital in Ahmedabad. As I said, we've got Neeta Ben Vyas, who is Emeritus Professor, Physiotherapy College and Cancer Rehab Center in Ahmedabad. Dr. Kumar Saurabh from Ranchi, medical oncologist at Sambhavi Hospital. Dr. Archana Datta, radiation oncologist at PIMS Hospital, Jalandhar, and Dr. Vijay Bhargav, medical oncologist from JNCH, Bhopal. And I'm Aparna Mittal. I'm the founder of Patients Engage, and I'm moderating this session. So, as I said, we have a very, very strong panel, and we've got lots of questions which we've already, planned. But if there are any more questions, please do share it, and we will try and cover as much as possible. So thank you for joining us to our panelists. I will start with, we were supposed to start with Dr. Meena, but she's not there. Dr. Vijay Bhargav, after the intensive, so we will be covering the various aspects of survivorship for breast cancer, ranging from lymphedema, menopausal symptoms, bone health, fatigue, body image, etc. even the prevention and diagnosis of recurrence, since that affects so many people, sexual and reproductive health. But let's start with you, Dr. Vijay Bhargav. After the intensive period of treatment is over, what are the ongoing treatments that patients may be put on? Is this for all breast cancers, or does it depend on a few different factors?
So definitely breast cancer is a heterogeneous disease. Though in a layman population, we can say that is a breast cancer, but every patient is unique. And there
Right.
is at least three subgroups that can be clearly defined in the patient population. One is hormone positive. Another one is Herceptin receptor positive. Another one is positive for all three receptors. And fourth one is negative for all three receptors. So the
Right.
receptor positivity and stage of the disease defined the maintenance kind of treatment or treatment, adjuvant treatment with intention to prevent the recurrence. And that is so diversified that in hormone therapy, we should put patient on some simple oral pills with minimal side effect. In triple negative histology, if there is a residual disease, then we should give some months treatment for capecitabine. Or if patient is positive with Herceptin receptor, then we should give some adjuvant anti-Herceptin blocking agent as an adjuvant. So that is depend on patient subtype. And that problem many times we also face in our practice, that there is a groups of patients are now aware. So this is sort of, there is a tablet which is ongoing with my colleague, my fellow patient, and I am not getting that. Someone asking me for target therapy in spite of being a triple negative histology. So definitely all those factors decide the treatment also, and adjuvant and maintenance treatment also.
Right. Thank you. I think that is why it's important for us to highlight this, that there are factors that, because, people see breast cancer as one thing, and while they mention this, it's HER2 and triple negative, etc., they don't understand that the treatment varies based on that. So one of the things we always tell patients is, just because in a support group, while you get information like this, it's important not to rely on the treatment protocols that some other patient is going through. Dr. Meena, thank you for joining us. The question I have for you is the importance of follow-ups after the intensive period of breast cancer treatment is over. So what is the typical follow-up routine, and why is it important? You're on mute still, Dr. Meena. Yeah.
It's fine.
Yes.
Yeah.
Yes. Thank
Am I
you.
audible? Yeah.
Yes, very clearly.
Good morning. It is. I'm right now in USA. I'm visiting my
Right.
daughter. So it's a
Right.
morning for me. So good
Okay.
morning to everybody. And yes, as you said, it's very necessary for our breast cancer patients to have a regular follow-up. Most of the time, our patients, once they are finished with their treatment, they feel, okay, now I'm over with my treatment and I need not to go to the doctor for regular follow-up. But that is a big mistake they are doing, because many a times, if they are situated far off, you have to really emphasize on the role of regular follow-up. So basically, I usually ask my patients to come every 2 months for a year for a regular follow-up. And the
Right.
patients who are on adjuvant hormonal therapy, they usually visit to me regularly and on a monthly basis.
Okay.
So because if we start on hormonal treatment, they have to get medicine they get medicine only for a month or so.
Right. Right.
So
Right.
they come to us for every monthly follow-up, and then maybe you can increase the duration by 2 months or 3 months for another 2 years. And then after completion of say 3 years, we usually call it 6 monthly basis.
Right.
So that's how we do our follow-up
Okay.
protocol. Yeah.
And from a patient perspective, why is the follow-up important? Why do you tell them to? One is, of course, they're coming because they're not prescribed medication beyond a certain amount. But what is
That's
why should they think that this is important?
Yeah, because whenever in breast cancer, once they are finished with their treatment is over. But many a times, physical examination is must for the contralateral breast,
Right.
which I feel is very necessary for all our younger patients who are especially triple negative patients. So clinical examination by a physician is must. And
Right.
then all routine investigations for to rule out any metastatic workup. That is
Right.
also a must. So routine ultrasound chest, ultrasound abdomen and chest X-ray, and routine blood investigations are must for our breast cancer patients on follow-up.
And you use the term contralateral, which means the other breast, right?
Other breast, yeah.
Right.
Yeah.
Thank you. Dr. Saurabh, in the follow-ups, do you only check for breast cancer recurrence, or is there a more holistic checkup involved?
The point being, breast cancer patient generally have to undergo systemic chemotherapy as a part of the treatment, and that in itself entails a lot of other risks, other associated risks apart from the recurrence of breast cancer. So as recurrence of breast cancer, apart from that, there are other things which you have to check. Let's say the patient is on a hormonal treatment. Now, the hormonal treatment which is given to the patient impacts their bone mineral densitometry. So, all the patients who are on follow-up checkup should get a routine bone mineral densitometry done. And if the bone mineral densitometry comes as to be low, then they have to take either supplemental zoledronic acid or calcium or whatever the doctor prescribes. Then many of the patients on follow-up are on targeted therapy like Herceptin. So if the patient is on trastuzumab or something, that impacts their cardiac status. So they have to routinely go for 2D echo so as to ensure that their cardiac status is normal. Plus, many of the patients who take intensive chemotherapies, they have propensity to develop a lot of metabolic disorders, including hypertension, diabetes. So a complete physical examination is mandatory at almost every visit, apart from the routine physical examination, which we do check for recurrence of blood cancer. But these things are also important. Yeah, I'm not able to hear you, ma'am.
So we've covered a fair amount of the effects of treatment. But Dr. Archana Datta, are there other long-term effects that you see based on your experience of treating breast cancer patients?
Yes. See, if the patient is suppose on drugs like tamoxifen, premenopausal ladies, we have to be very careful about the endometrium.
Right.
Endometrial thickness is one very important aspect. Then secondly, the patients who are having hereditary breast cancers. So in those patients also, we have to be very careful because they may be prone to develop other malignancies. We do find ovarian, endometrial, and sometimes patients who are falling under some other syndromes. During follow-up, we are able to catch them up early. So
Right.
these are the aspects which we have to take care. And also patients who have undergone chemotherapy. So especially younger patients who have undergone chemotherapy, we have to see how is their fertility aspect. We have to guide them accordingly. And in fact, before chemotherapy also, we have to discuss with them.
Right.
As far as older patients are concerned, especially bone health is one very important aspect, because those who are on aromatase inhibitors, as it has rightly been mentioned, that DEXA scan for bone densitometry is very, very important. And we need to supplement these patients before they develop any skeletal events.
Right. Okay. Thank you, Dr. Archana. Dr. Saurabh, quick question. Actually, no, before that, Dr. Bhargav, patients often fear follow-ups, or as we found that they think it's a low priority. In your experience, what can be done to improve that follow-up?
I can say that breast cancer, after completion of treatment, there is a new, I can say there is a second life of the patient. One is before the treatment, another one is after the treatment. So in every encounter, we have to simultaneously emphasize the importance of follow-up, risk of recurrence, along with the good life support, and all the related issues should be addressed. I have in my one of my close friend is positive for stage 3 breast cancer. After treatment TMH, she got on the 6-monthly follow-up, and within 1 or 2 year, they planned a pregnancy. And as she was on hormone therapy, and they are affordable for all the treatment options available, so they have chosen some surrogacy. And unfortunately, after visiting TMH, she came to know me that I have some issue of breathlessness. I just get a PET scan and she is positive for stage 4 breast cancer.
Right.
So that is, I think, I am criticizing an institution or any person, but I just want to say that very close contact with patient even after treatment is equally important, as we are in touch of the patient at the time of treatment, because we as a clinician know better about the risk of recurrence and the fear of the disease if that comes again. And many times patient is just counting the days that now my chemotherapy is over, my radiation is now over, and I am free of the disease. That is right. But simultaneously, we should encourage them to regular follow-up. One, by giving the hope and giving the help you are providing after each and every follow-up to make their life easy, then they would definitely come for the follow-up. And simultaneously also dictate, also advise them the possibility that there is always chance of recurrence, though that is lesser with increasing years, especially in triple negative and HER2 positive, the recurrence is high in early years, but hormone positive may recur later, and there is no thumb rule of cancer. Anytime any patient will end up in the recurrence, and at that time again early treatment help the patient to live better life. So simultaneously encouraging them for follow-up with some good support of medicine and psychosocial support, and also simultaneously giving them the explanation that if you lost the follow-up, then many times such kind of things may also happen.
Right. Thank you, Dr. Vijay. Dr. Saurabh, are all patients at risk of lymphedema, or only some patients?
Generally, when we earlier used to treat breast cancer patients, when the standard of care was level 2 axillary dissection, lymphedema was a very serious problem. But over a period of time, we have gone into the concept of sentinel lymph node biopsy. So those patients who are having a sentinel lymph node biopsy only, and that sentinel lymph node comes out to be negative, they don't have a complete axillary dissection. So we have more or less controlled lymphedema problem in at least in early stage breast cancer patient. Yes, but lymphedema is still a serious problem, and it is one of the most irritating problem. Not very serious in terms of risk to life, but it is very irritating in terms of quality of life. So lymphedema is something which almost 60% of the patients who have undergone axillary dissection do complain of that. And the problem is lies that there are no medications available for that. The only way to avoid lymphedema is to go for exercise, physiotherapy. We generally avoid, ask the patient not to take any intravenous injection in the affected arm. So that way we can reduce lymphedema. And plus those patients who undergo breast conserving surgery, who undergo radiation to the ipsilateral site and radiation to the axilla, they do have an increased incidence of lymphedema. So the only thing which the patients can do is first to avoid getting any intravenous injections on that arm. Take care to avoid any trauma to that arm, because any sort of infection to that arm will lead to increase in lymphedema. Plus regular exercise with preferably with a physiotherapist do help the patients in dealing with this problem.
So I think, based on our conversations with various patients, I think it's more than irritating. It's actually fairly debilitating and takes up a lot of time in managing it and affects them in a lot of ways. Neetaben, for a long time, lymphedema and other long-term effects, I think lymphedema for a long time was called the dirty little secret of breast cancer. In your view and your experience, has this improved? What is the level of information that patients are now being provided? And, especially with your perspective of also having been a cancer patient yourself, What is the level of information that patients are being given, and what are the gaps that you still see?
The improvement in lymphedema therapy has improved. The thing is because there are lymphedema therapists and oncotherapists who are working with some of the surgeons. So day one, they start that physiotherapy and they are given some advices like not to carry weight, as Dr. Saurav said, that they cannot measure their blood pressure on that arm. They cannot take any intravenous injection in that arm. They should not wear any tight clothes. I mean, there are lots of advices to be given to those type of patients to prevent lymphedema from day one. So there are, I mean, in last 5 years, I have seen myself, if I say myself, I have not developed lymphedema till now by God grace, but that is because of exercise programs or advices or whatever I know I have been doing. But if by chance, if we get a patient who has started lymphedema, we go with them for exercise programs, we go with them for some CDC programs, like we give them complete decongestion therapy, where we have seen, I mean, I have seen one patient of 10 years post lymphedema with lymphedema, and we treated that patient for continuous for 1 month with this bandaging, with exercise, manual lymphatic drainage and everything. She was as normal as before, like, so she has changed in her quality of life also. So that is how, if the patient is referred to a physiotherapist from day one post surgery, so the proper physiotherapy is done. They are being given advices, because deep breathing exercise really helps in preventing lymphedema. Where
Right.
we do lots of deep breathing with pranayams and all those, it helps in preventing lymphedema, whether the lymph nodes are removed or not removed, but that is the main therapy which a patient should go post surgical and during chemo and during radio, which will prevent them from lymphedema. So now awareness has come in many ways when the patients are going for chemotherapy or radiotherapy. They are being told what to do, what not to do. So that is how recently the patients are being prevented from lymphedema.
Thank you, Neeta Ben. Dr. Meena, let's talk about menopausal symptoms. Do they kick in for all breast cancer patients or only for those on certain treatment protocols?
Yeah, not all the patients, but yes, few patients, they have really bad experience with the menopausal symptoms. And I believe, okay, we need to prepare them with during the treatment itself. Many a times during chemotherapy only, young patients, they are bothered about having menses being stopped and all those things.
Correct.
So you really have to be very from the beginning itself. You need to, for the young patients, you need to counsel them regarding the incidence of getting menopause. Maybe it is temporary or as a permanent phenomena. And then maybe a lot of reassurance is needed in young patients, because many a times females, they feel that once it is like I attain menopause, I cannot carry with my reproductive life in future. So you really need to take help of some counselors also in this matter. So,
Right.
yes.
Right. Yeah, and I think also a lot of the other for the ones for whom menopause becomes permanent, I think it kicks in a lot of other dryness, and including vaginal dryness, etc., which is quite problematic for, as you said, for younger patients more so as well. Dr. Mithun, thank you for joining us. Let's ask you about bone health. What should patients be doing to manage bone health after? Because bone health often suffers for post breast cancer treatment, either because of menopause or because of the other treatments as well. What should they do to manage bone health?
See, bone health is very important in the overall management of cancer patients. We will discuss only the patients whose disease has not spread to the bones. Then it becomes altogether different.
Correct.
So bone health is important because many of the times the patient, the age is there, they are menopausal, their menopause has set in, plus the treatment has led to early menopause. So they are prone for osteoporosis. So the patient should be should be counseled about adequate calcium intake, sources of calcium. Plus, they have to be given calcium supplements. And if the patient is too fragile or very weak, we tend to get the baseline bone mineral density in patients. And if on treatment, if the patient is taking the hormonal treatment, especially the postmenopausal females, where we give that aromatase inhibitors, their side effect is it can increase the osteoporosis. So if you have baseline osteoporosis, you start treatment of osteoporosis by adequate calcium supplements and few injections like zoledronic acid or denosumab, which has to be given. One is every 6 monthly, one is every 3 monthly or 6 monthly as an prevention of osteoporosis. Simultaneously, we have to continue the treatment, hormonal treatment. So it should go both hand in hand. The treatment should not suffer, as well as you should manage the osteoporosis.
And do we as a protocol do bone mineral density test before the treatment begins? Before any treatment
Especially,
begins?
Ideally, it should be done before you are prescribing aromatase inhibitors like letrozole or anastrozole or exemestane. In younger patients, we can omit. But in elderly patients, more than 55 to 60 years, ideally it should be given. But if it is a resource constraint and patients cannot do it, we should give calcium supplement at least to begin with.
Right. Neeta Ben, what is the role of exercise in bone health, fatigue management, and psychosocial mental health? You are on mute, Neeta Ben.
Sorry. As said by Dr. Mithun and others, due to some early menopausal changes, due to hormonal therapy, there are chances of patients getting osteopenic or osteoporosis. So by physical therapy, at least we can help them by giving good exercise program, because we have seen that physical activity has good role in preventing osteoporosis, osteopenic, and even prevention of cancers also, because physical activities has very much power in whole body. So what we do as a physio, we take them on good weight-bearing exercise programs which they can do at home, because the medicines are being given as said by the doctors, supplements, but weight-bearing exercise always help in preventing this osteoporosis or osteopenic. As a physiotherapist, we do that. Secondly, as you said, for socio-psycho development, as I said now, the problem which many times patients have, this it starts when they hear day one that they are having cancer.
Right.
So that is the only main word they get it, and they are, I mean, they feel like their whole life is gone, or their family is gone. That is how they feel it. But whatever I mean, as a doctors, they counsel it. But when as a physio, we are there with them every day for their exercise program, post-surgical, during chemo, during their radiation. So if we then tell them, let's see, if a good family, we counsel with their family also. If a good family support is given to a patient, then they mentally they are less disturbed, and then the treatment gives them a good results. That is what
Thank you.
I have seen in the patients.
Sure.
Because I had one patient whose husband was not ready to accept this cancer, I mean breast cancer. That was how that patient was disturbed. Like when his husband used to ask some very few, I mean very, I mean, I'm not able to speak those questions, but that were very really hurting questions for me too, and for that patient too. So I had to counsel him that if you had this thing, how would you take, how your wife would have taken you?
Right.
So the way we try to counsel the family and the patient and bring them out of that psychological disturbances, so that mental stress would not hurt them, and then they can have very good, I mean the medicine have that good effect, and that positive would also help them to have a good quality of life. So I strongly believe myself that as a physio, if we are with the patients, it is our duty to help them to come out from that psychotherapy and gain their confidence. Let's see, cancer is not cancel. If you really, cancel means CANCEL.
Right. Right. Right.
So I tell them that
Mm.
please, if you can live a positive life like this, you can really get out of this disease with the help of the family, your husband, your friends. So be positive, come out from that. And if you will do these things, you can help yourself in every aspect. So that
Right.
is how we try to make them being out of that socio-psycho and every taboos that they are undergoing.
Right. Thank you. Thank you, Neeta Ben. Dr. Archana, you earlier talked a little bit about younger patients having, issues or concerns on ovarian failure and fertility impairment. Can you talk a little bit more on how this can be addressed, and should this be addressed before the cancer treatment, after cancer treatment? What are the things that patients, if for any reason the doctor does not bring it up, what should a patient be actually raising with the doctor?
Yes. So whenever a young lady is visiting us, especially a premenopausal lady comes to us, her obstetric history is very important. We have to ask whether she is having kids, she's not having, she's planning for one. Because whenever, before we are giving chemotherapy, we have to get a consent form signed from the patient.
Right.
So in that consent form, we have to mention that the drugs, most of the time, the drugs are all cytotoxic drugs.
You've muted yourself, doctor.
Hormonal therapy as the only treatment modality, but most of the time, once chemotherapy is used, we have to tell them regarding fertility. So
right.
Yes, nowadays we do have options of ovum preservation, and we before starting treatment, we make it a point to fix up an appointment with the gynecologist, and if they are keen for ovum preservation, we do let them do that, and afterwards we follow the chemotherapy. So
right.
that is important, and sometimes even despite telling the patients, initially they may not be that much inclined towards this ovum preservation concept. But later on, once they are disease free and they are on follow up, then they keep asking us that what are the now various procedures that we can have. Most of the time, ladies who are disease free for 5 years or so and would like to have a child, they do come and discuss with us. And in that case, we have to give them the options of either donor ovum, or again, we have to talk whether we can do anything to enhance their fertility. All these things we have to discuss with them.
Right. Thank you. Thank you so much. Dr. Meena, in your practice, and I think Dr. Mithun, I'll ask you as well, in your practice, what do you see as the long-term effect? I think Neeta Ben talked a little bit on the effect on social life or family life of the patient. But in your experience, what are you seeing as the long-term effects for the younger patients? Are they able to return to work, or are there misconceptions that that you want to address in this forum?
Yeah, like I believe I'm in oncology from last 25 years now. Initially, in the beginning days, I used to see people were more depressed, but with the awareness, more of awareness on social media and other platforms, I believe patients are taking it more positively. This disease, it's incidence wise also it's increasing a lot, and patients usually they get some information on social media also, and then more involvement of doctors in this aspect is helping a lot to our younger patients. And seeing the more cancer survivors in the society, they are more positive about their disease.
Right,
So definitely, yeah, there is a change in the acceptance of
right,
cancer patients in the society. So
right,
it's a good this thing for the cancer patients, and more awareness is needed, especially in our country. So
right,
maybe we will
right,
be able to help our younger patients in a more better way. Only
right,
thing
right.
is you have to talk to the patients. Many a times being in a busy routine, many a times doctors avoid talking to the patients, but I feel talking and discussing with the patient is must, and not only the patient but the entire family has to be
Family.
involved, especially
Right,
the spouse and their children,
right.
so that
Uh,
they are better accepted by the society.
Right,
Yeah.
right. And Dr. Mithun, do you see it different for elderly patients? I think as Dr. Meena said that the younger patients are on social media, they are seeing role models, etc. Do you see it different as to the attitudes towards elderly patients?
Uh, Elderly patients, sometimes generally the diagnosis is slightly later. They come with an advanced disease, plus they have the fixed concept like they will not take chemotherapy or the standard practice. But nowadays, what we have seen that even a 70-year-old is quite fit. So we
Mm,
try to give the standard treatment.
right,
It is the number, but the overall performance status and the strength of the lady, which is important, and only age should not be a criteria to give suboptimal treatment. Otherwise, as said before by Dr. Meena also, there is the psychological support is important, and people are taking it very well as it is the number one disease in women's, so they are taking it positively. And the only thing is that if they're diagnosed in an advanced stage, then we have to manage it in like a chronic disease. So it is a long journey with the oncologist, the
correct.
psychologist, the physiotherapist. The whole team should be there, especially, and they should come at appropriate time and try to help the patient.
Right. Thank you. Um, uh, Nita Ben, one question that has come up is, can patient do MLD themselves? And if you can explain what is MLD.
Now, patient can do MLD themselves. We teach patients.
Sorry, what is MLD?
Sorry, I'm very
Hmm.
sorry. MLD is manually lymphatic drainage.
Right,
Okay. So it is like one type of, you can say one form of soothing type of massage done by
right,
a therapist. But actually, in starting, it should be done by a lymphedema therapist only,
right, right,
because it is a special course done by this particular therapist. Which, uh, that is how they see the total lymphatic drain. I mean, system is seen. They see how many lymph nodes are being removed,
mm,
how much is the edema. They measure both the arms, the normal one and the affected arm. So in starting, they should go to a lymphedema therapist. Once it comes, I mean, if it is reduced in a week time, then they are taught how they can do at home, and they can come up for follow-up. If they have some caretaker, the caretaker is being taught how this particular drainage is being done. So it helps. And once the drainage is done, I mean, the treatment is given, then there are some bandages to be given on that particular arm. And the bandaging is very important to prevent that lymphedema coming back. So in starting, they should go to a lymphedema therapist, and then gradually, once it is relieved, then they are being taught to the caretaker, or by themselves also they can do it. So it is
Thank you. Thank you. Dr. Saurabh, can recurrence or secondary cancers be prevented?
Most of the recurrences can be prevented by strictly adhering to the adjuvant adjuvant hormonal therapy or adjuvant HER2 directed therapy, which has been prescribed. The problem is many of the patients they stop taking these drugs, especially those coming from a poorer socioeconomic status. So generally the concept is that once the treatment gets over, the patient is put on some oral tablets, then they don't realize the importance of these oral tablets. So it is very important for the caregiver to emphasize on the importance of completing the total period of adjuvant therapy, which ranges from 5 to 10 years. Second important thing is follow-up. Many a times, especially in the hormone positive patients, the disease, even if it recurs, the recurrences are local in nature, and it may get cured again with proper treatment. Even if the recurrences are distant, systemic in nature, then also finding out the recurrence at an appropriate period of time will give the clinician the advantage of treating it properly, and so that the patient can have a long and effective quality of life. So that is what is important. But coming back to your point, can the recurrences be prevented in toto? I believe that is not possible. So there is always a chance of recurrence, and that has to be explained to the patient beforehand.
Right. Thank you. Dr. Vijay, there's also sometimes the feeling that if I've not had a recurrence after 5 years, or I've not had any other cancer after 5 years or 10 years, depending on, the patient has different perspectives, they kind of that worry obviously goes away, right? So initially they're very worried, but then it goes away, and then they start to think that it won't come back. What is the risk of recurrence after a period of time? Does that risk reduce? Does that risk stay constant? How would you explain that to a patient?
Definitely, in a early breast cancer, if node negative disease is there, then there is only around 6% recurrence risk. If patient is having early breast cancer with node negative status, but if patient is having node negative or regional spread is there, then it may recurrence risk.
Sorry, I think we lost you.
May local complete chemotherapy, then adjuvant radiation, then in node negative positive disease also there the recurrence rate decrease. So for the general population, I just want to say that definitely it's again depend on the type of histology, and like in triple negative histology or HER2 positive histology, the early recurrence is more common, and then later after 5 years the recurrence rate decrease, but it is never zero in any histology. So that is the point that should be in mind of every patient. And though our motive is not to put them on fear for life of recurrence, but they should be aware enough to know about the recurrence risk which attached with the every patient. And in hormone positive, there is a late recurrence is there, but recurrence happens in any patient, irrespective of stage. Though there is data about the more recurrence in advanced stage, less recurrence in early stage, but there is no rule. Many patients we have seen that in stage 3 also they don't have recurrence for a long time, and many early disease, even T1 lesion may goes to the brain, especially in HER2 positive histology, and there is no explanation of that. Basically, breast cancer is a systemic disease, so we should explain about the recurrence rate to all the patient. And the only thing which my colleague has already emphasized, that if recurrence happened, then still many patients are curable, And if cure is not possible, then longer overall survival of PFS benefit is there if we got early detection of the recurrence in metastatic stage also. And the varied of the therapy options available, especially in hormone positive patients and in HER2 guided HER2 positive patient, that is only benefited to the patient if they have a plenty of or enough time for the therapy. So the emphasis should be on the regular follow-up. The frequency is decreased, patient may relax and they should keep enjoying their life, but simultaneously they should also keep in mind, a corner of the mind, that my disease was there and we should be aware of that, and we should always taken all the precautions and we should follow the regular follow-up schedules. Then we can defeat the disease.
Right. So since our topic is challenges in care for survivorship, and we know that as the patients are surviving, more and more patients are surviving, and our doctor patient ratio is still very low. And we still, while we have, people like Nita Ben who are active in lymphedema therapy and other aspects of therapy, but I think we still do not have enough specialists for various aspects of supportive care, psycho-oncology, lymphedema therapy, etc. How can we bridge this care gap, and what can we do to improve patient outcomes? And I'll go around to, I think, all of the panelists. If each of you can give a couple of points on this. Dr. Meena, we'll start with you.
Yeah, I believe we should form groups of cancer survivor group is already there. Breast cancer survivor group is there, and it's working in quite a few cities very well. Like in Chandigarh, we have a very good group of cancer survivors, and they are holding regular meetings and all those things. So every oncologist should encourage to form one such group in their hospitals also.
Right.
So that more and more ladies gets involved in the this thing, spreading the awareness and what all trauma she has gone through. She is the best person to explain the cancer patients who are undergoing treatment.
Right.
So I would emphasize more on breast cancer survivor groups rather than because clinicians, they don't have that much time.
Correct.
And many times important aspects are missed by the doctors. And I think there are many questions which patients want to ask.
Yes.
But in presence of so many other patients and other things, they may not be able to get the answers. So
Correct.
such groups will definitely help them in getting their queries satisfied. Yeah.
Right. Thank you.
So,
Thank you. Dr. Mithun?
Yeah, I think that's a very good suggestion by Dr. Meena. I would still emphasize more on the early diagnosis part, and breast self-examination from the age of 30 and mammography after the age of 45 should be included in routine health packages. So if we are able to diagnose in early stage, we'll be able to cure more patients. So that is what I would like to emphasize on this platform.
Thank you. Dr. Archana?
I personally feel media can play a very important role. If regularly Government of India and various other private sectors, they join in hands along with we clinicians, and regularly we keep posting about whether a lady who is able to find out a breast lump, which may be a painless breast lump especially. Most of the ladies, they do come to us saying that the breast lump was there, but it was not causing any problem to them, and that is why they had not come in for any healthcare checkup. So
Correct.
this we have to emphasize few signs and symptoms. I think if we make it an advertisement or some sort of thing comes in media daily regarding this aspect, we'll be able to definitely catch it up early. And obviously volunteers who would like to join in at local levels, we can form those groups, and definitely it will be very beneficial for the society.
Thanks.
Especially ladies who our film stars who had suffered from these diseases, they can come and lead the forefront, be the brand ambassadors in giving awareness about this topic. And I'm sure that in a country like India, where media plays such an important role, even a rickshaw puller is having a mobile in his hand. So I think that will definitely play a big role.
Thank you. Thank you. Dr. Vijay?
Yes, ma'am. Most of the issues has discussed about the, but I just want to emphasize that don't be frustrated or be negative about the patient-doctor ratio, because as we can say in NHS in US, there is a longer waiting risk of the patient waiting list for the patient as compared to India. We have a very refined system of practicing medicine and even medical oncology also. In a one day, a motivated patient can want to approach you. He can approach or consult you with a supreme qualified doctor of the country, and next day he can get done an imaging of MRI and mammogram, and third day he can have a third or fourth histopathology report. So the many times hierarchy of the Western world or the such kind of elite countries cannot perform as competently as our doctors or our Indian fraternity is doing. So we are tuned for the mass population, and we can screen out them early, and we have a lot of shortcuts to get better result than those people. Definitely, as ma'am told, that there should be a screening system. We can have a questionnaires, we can have a supporting staff for lymphedema, physiotherapy, and sexual psychosexual issues. And after that, a patient came to you on the follow-up, then he is free to ask one or two questions which is not answerable, answered by the your colleague. And many times patient want to listen from you, and your credit is unparalleled as compared to other your supporting staff. So on the systemic way, we can keep doing better and better in spite of a so-called limited resources, and we are doing that also. And community participation, patient participation, especially survivor of the community, many questions came to them. How you know about your disease? What is the problem you have faced? Anytime a layman encountered a patient, he's fear that I should not suffer with this disease. Then they ask how you came to know, how you approach the doctor, how you know that you have a cancer. So that is the hidden instinct of the questioning people, that I should not get that. And definitely with that awareness, more and more people can get early consultation. That is the only way to reduce the mortality and get better and better result.
Thank you. Dr. Saurabh?
I believe, ma'am, the most important aspect here, especially from coming from a relatively poorer state of India, I would suggest that the most important aspect here is to educate our primary care physicians and surgeons. So they are the people who the patient approaches first. Even after completion of treatment, they are the people who are constantly in touch with those patients. So survivorship issues, long-term complications issues, plus as Dr. Saab mentioned, early diagnosis. So that is where we are lacking. And self-breast examination and media awareness, all that is very well, but that is for our educated population. The plethora of most of our population is still very uneducated, which with limited access to internet and media. So the important thing is to educate our government sector doctors, those doctors who are practicing in PHCs, so that they are able to recognize breast cancer at an early stage and do a proper referral. I believe a proper referral is something which lacks, especially in this part of the country.
Right. Thank you. Neeta Ben, from your experience, anything that you would like to add to this?
First of all, I would like to say that if the cancer hospitals are working, they should have an oncotherapist or a lymphedema therapist with them. So at least their post complications are being looked out, number one. Number two is like already I have written a letter to government that if it is possible for government to put mammograms at all their CHC and PHCs, so at least the patients in the rural area, they can be screened out. But at the same time, most of the patients, they go to their GPs in early stage. So all the GPs should know, they should keep all the physical examination posters and all the details of this breast cancers at their clinics out where the waiting area is there. So at least when the patients, general patients, when they go to that clinics, they read about this. So awareness would come like this. And as said by Dr. Meena and Dr. Ashna, media, the TV, local Doordarshan would play very good role in this to bring the awareness in patients, like how they should examine by themselves, because there are good videos also.
Right.
Like what we have started is like we work in community. So we go to that community, we take those videos with this, we collect the ladies uh, nearby and we show them the videos that see, these are the things you should take care of. If you have any kind of this, you can contact in civil hospital or in these hospitals to prevent yourself from all these things. That is how the awareness programs are done by the colleges where we see. And already the universities have now started that they would tell the university, I mean the colleges, that every girl who is above 25, suppose if the master's programs are going on, or in all the faculties working in the university colleges, they should compulsory undergo mammograms. So at least from there also the things are being prevented. If they are screened out, they can very well be prevented if they have early some problems in their breast,
Right.
or any other ovaries, or it can be a cervical cancer or whatever. So at least the vaccines are being given in the colleges, which an NGO Rotary has started, and most of the colleges in Ahmedabad, they have taken this project and they are being given. But number one is the government should initiate all these programs. So at least the GPs, if they are trained, all the CHC, PHCs, government, medical officers are trained, then we can very well prevent all this.
Yeah.
The
Thank you.
breast
Thank you,
cancer.
Neeta Ben. Yeah.
Thank
Yeah.
you very much.
Yeah. So I think we've kind of covered a fair amount of ground today. We've talked about, lymphedema. We've talked about menopausal issues or postmenopausal. We've talked of bone health. We've talked of psychosocial health. And we've talked of the various treatments that are there. We've also talked of the importance of not just doing the intensive treatment, but also making sure that you kind of complete the course for the adjuvant therapies, or whether it's the oral chemos or the hormonal medicines, etc. And I think these are very important, because we found when we looked at some of the data from the government that even the packages that include those treatment protocols, that part of the treatment often does not get claimed. It's only the surgery and the intensive treatment that gets picked up. So I think it is important to highlight, as each of you has done, on the importance of adhering to the treatment that is prescribed by the doctor, to continue with the follow-ups, and to make sure that the follow-ups do not just focus on the tumor markers, but also look at the holistic quality of life parameters as well. And as Neeta Ben talked about, the importance of exercise physiotherapy as well. So thank you to our panel and to Biocon for facilitating this. We, as I said, we have covered a lot of grounds. There's a lot of action items for survivors here to kind of follow through, but also to our doctors to ensure that they, as Dr. Meena said, communicate more with the patient and their families, and to use the power of the community to spread the message. And as Dr. Archana said, the media. Dr. Saurabh said about ensuring that the people at the at the PHC levels are trained. So there's a lot of action items that each of us will have to contribute towards. But I think all of these will go a long way in ensuring that we can improve outcomes for survivorship. But I always say this, that for survivorship, patients and their families will have to take a much more active role, because they know what they're dealing with and they need to advocate for themselves and, raise those points. So thank you once again to each one of you for contributing
Thank
and
you.
participating in this panel.
Thank you, ma'am.
so much. Thank you.